Good morning, good afternoon. I'm Benedict Walter from the Secretariat of the Network for Improving Quality of Care for Maternal, Newborn and Child Health. Welcome everybody to this second webinar in a series on transforming care for small and sick newborns. The series is organized by UNICEF and the World Health Organization in collaboration with the Network for Improving Quality of Care for MNH. You are all muted on entry, but please do interact with the speakers by typing your questions during their presentation and your comments in the chat box, which is in the bottom right corner of your screen. During the second part of the webinar, the speakers will answer those, so please go ahead and type your question while they're making their presentation. I would like to introduce today the facilitator for this session, which is Dr. Ornella Lincetto. She will drive you through this session this morning. She's a senior medical officer for newborn health at the World Health Organization in Geneva and the lead editor of the Survive and Thrive report. Ornella, over to you.
To all to this webinar, we will discuss, which is, as you know, a series, part of a series on to describe the Survive and Thrive report, transforming care of every small and sick newborn. And this report has been the collaboration of the result of collaboration of many partners. So you can see their logos, but many more people were, of course, involved from 16 countries and about 100 authors. Why the report is important? Because there is urgency to meet the SDG targets, and particularly we are interested in reducing neonatal mortality rate and stillbirths. We want also to ensure universal coverage, particularly for small and sick newborns that are the most vulnerable group among the children. And then finally, we think there is also a big opportunity to really accelerate the progress despite now the COVID epidemic. So today we are discussing chapter 2, which is focusing on what are the numbers. To introduce the presenters, the agenda, of course, and the presenters. So we will the presentation on the key findings of the report done by Professor Joy Lone, who is a pediatrician, currently director of the Maternal, Adolescent, Reproductive and Child Health Center at the London School of Hygiene and Tropical Medicine, and also lead editor of the report. Then this will be followed by a short presentation on the experience of Nepal by Dr. Ashish, who is a pediatrician and a researcher specializing in quality of care, and is based at the Department of Women and Children Health at the University of Uppsala in Sweden. And then we will have a presentation also from the Gambia on the challenges of a hospital-acquired infection in neonatal units in West Africa by Dr. Udo Okomo, who is a pediatrician and epidemiologist based in MRC in Gambia. And then finally, I will present only 2 slides on the latest data on COVID-19 in pregnant women and newborns. And finally, we will have the question and answer session. So please send your questions in the chat. Thank you. And I hand over to Professor Long with her presentation.
Who have contributed to this topic. I'm going to be sharing with you what the numbers say. We have data, we have a big problem about small babies, but how can that data help us to change the situation, especially for these most vulnerable newborns? And the report is called Survive, Thrive and Transforming Care. And the key findings for this chapter on the numbers are also organized by those headings. First of all, survive, the first right of every human. And small and sick newborns are the most vulnerable and account now for about half of under 5 deaths. We have an urgency, just 10 years to go, and a double urgency because of some of the can I be heard okay?
Yes, you're fine.
good. Okay. I thought I was being told to unmute. Okay. So we have an urgency with just 10 years to go, and actually a double urgency because of the pandemic. And I'll show a slide here about some of the risk from that and the critical need still to keep a focus on these most vulnerable newborns. So survive, thrive. Really important to recognize that parents want their babies not just to live through the first month, not just to reach their 5th birthday, but to thrive. The whole agenda linked with nutrition, child development, preventing disability. And the disabilities that we're at risk of for these newborns are also preventable, and we need to keep them in our sight from the start. And investing in this way is one of the most effective investments we can make in human capital. And then moving to transform. How do we transform our health systems and also social norms? And what are the data to drive that? How many newborns are at need and what sort of care do they need? So as Ornella has said, the critical hook or focus is the 10 years left to the Sustainable Development Goal target in 2030. During the Millennium Development Goals, we focused primarily on survival, and it was only at the end of those that we realized that around half of our child deaths were in the neonatal period. So we have, for the first time in history, a target for neonatal mortality rate reduction, and critically linked to carrying forward on under 5 deaths. But we also have an agenda to thrive, and this is an important part of the investment case for small and sick newborns. Looking at child development, optimal education, and then the critical importance also of wider transformation of our health systems, but also social norms. So one of the reasons it's taken so long to get newborns onto the agenda is because of gender inequality. Often these deaths happen to the woman with the least voice. And then to measure these targets, there are many different types of data needed. And this is a list just of the critical data. So some of the core indicators within the Every Newborn Action Plan. And at 4 weeks from today, there'll be a presentation on chapter 5 of this report, which focuses on the data and how to improve that, led by Dr. Louise Day. So moving through the findings, survive, ending preventable newborn deaths. We have the first target in history, but what data do we have to show us what to do, where to do it, and who to focus on? So each year, still 2.5 million newborn deaths. And those deaths are not equal to, for example, the urgency of adults dying from infectious diseases of a new virus. Many of these deaths are not counted in the same way, even though they count to families and to societies. Importantly, an almost equal number of stillbirths. So that's the bad news. The good news is that for the first time in history, having clear targets brings a way forward. And the Every Newborn Action Plan, based on country consultations in more than 100 countries, set a target not just for neonatal death reduction, but also for stillbirths. That was at the demand of country consultation. The neonatal target was included in the Sustainable Development Goals, and that's the first ever target for newborns. Stillbirths were not in the Sustainable Development Goals, but need to be kept in our lens. So as we look at this target, the target is an absolute target, so that by 2030, every country in the world should reach a neonatal mortality rate, so deaths within the first 28 days of life, of 12 deaths or less per 1,000 live births. And so with that target, we need to change the rate of progress. If we don't change the rate of progress for newborn deaths, then the newborn deaths alone could account for all the deaths within the under 5 target. So this is absolutely critical. The good news is that more than 78 countries have set a specific target. And for many of you online, your countries will have a target. Find out what it is and hold people accountable for it. And excitingly, more than 90 countries are implementing an action plan, and WHO and UNICEF's leadership has been key in taking that forward. However, more than 40 countries need to more than double progress over the next decade. So what data do we have to drive that? Well, first of all, where? So in terms of regional progress, what this graph shows is the projected date for each region of the world to reach the national target for neonatal mortality rate of 12, that's the UN blue line there, or to reach the same rate of neonatal mortality rate as high-income countries. So if your country is already below a neonatal mortality rate of 12, it doesn't mean you've ended preventable newborn deaths. Getting to 3 or 2 is preventable newborn deaths. There's still an agenda ahead. But for the accountability in the Sustainable Development Goals, and particularly in high mortality settings, the focus is to get to 12. And the 2 regions that at the moment are projected to meet that late are Southern Asia and Sub-Saharan Africa. And these 2 regions account for 2/3 of newborn deaths. But if we move from regional level to country level, for some countries, and particularly some African countries, it will be more than a century before those newborns have a same chance of survival as a newborn in North America, Europe, or Australasia. Now, I was born in Africa, and I think for all of us, this is something we shouldn't accept. We have to change it. So if we move to looking at the countries, what this map shows is orange are the countries with the slowest rate of progress, those most at risk of not meeting the target. Now, you could be moving slowly, but already have a fairly low rate, for example, North America. But the biggest challenge is if you have a high rate and slow progress, and that's particularly in humanitarian settings. However, the best way to help people move faster is to look at your neighbours who are moving faster. So in every region of the world, there are countries that are making fast progress. So for example, in Southern Asia, Bangladesh is the fastest. In Sub-Saharan Africa, Rwanda has just overtaken Malawi. So Malawi was the fastest during most of the MDG era. What can we learn from these other countries? And then if we look at the 10 fastest progressors over the last 15 years, so from 2000 until now, so we have almost 20 years of data, all of these 10 countries have invested in small and sick newborn care, and particularly with respiratory support for preterm babies. That is really critical to faster progress. But as we know, progress is threatened by the pandemic we're in at the moment. So we learned during the Ebola epidemic that coverage of care goes down. So as well as the direct effect of the epidemic on families all over the world, which we're all feeling at the moment, we also know that people are less likely to come to hospitals. Women are less likely to come and give birth in hospitals. Babies and sick children are less likely to be brought. Vaccination rates go down. So this is a very important paper released about a week ago, which suggests that even if you have 6 months where coverage of care is reduced by 15%, we'll get more deaths, and by 45%. So for 6 months, we have around a halving in births in hospitals and care. These are the potential consequences. Thousands more maternal deaths, and this is particularly sensitive to care at birth, and more than 1 million newborn and child deaths. So in these days, it is critical that we still find a way to keep our essential services going, especially for the most vulnerable. And if we move to then thinking about when, so we've talked about where, we've talked about the risk of COVID, we've talked about time trends, but when is the critical time to focus, both for women and for newborns? It's the birthday. So on their birthday, about 1 million newborns die, their only day of life. And yet most of these are preventable. And on the same day, about 1.3 million intrapartum stillbirths and a high proportion of maternal deaths. So this day is your greatest risk of death and disability. That's the negative side. On the positive side, you have the potential for a quadruple return on investment. So as Mark Twain said for all of us, two most important days in our lives: the day you're born, you celebrate your birthday, and the day you find out why. And if you're on this webinar today, maybe you're already very committed and doing things that make a difference for women and for their newborns. But if not, and you're looking for something to do, this is something that can make a big difference. Who to focus on? Well, in all that we look at in data, we look at the important construct of sex, risk, and gender. So baby boys have a biologically higher risk of death in the neonatal period. That's why there are about 20% more boys born normally. But girls are at increased social risk. So tracking this in our data and making sure we're equitable is critical. And then for focus on risk, small newborns are crucial. So about 80% of our newborn deaths are in vulnerable low birth weight babies. 2/3 of those are preterm and about 1/3 are term small for gestational age. And that plays into the cause of death pie that we know. So this pie chart is led by the World Health Organization data group. It reflects 195 countries' data. And often we think of infectious diseases in children, and this is important, but it's now about 1/4 of deaths. 47% of deaths are in the neonatal period, and in fact, there are 3% after the neonatal period due to neonatal complications. So about half of deaths are due to newborn complications. We've focused in the past on 3 main causes of death, and this report makes a shift to 5, because we're moving into an era where congenital conditions and jaundice are coming up, just as we see the shift around the world. So the leading cause of child deaths, not just newborn deaths, is preterm birth. Fundamental to do better. We fail often on prevention. We have not much in our armamentarium for prevention, and we need to do better on that. And critical here is better care. Birth complications, neonatal infections, and we'll be hearing from Uduak later. And in the session this afternoon, we're going to be hearing on congenital conditions. And where to focus? So now that almost 80% of all births worldwide occur in hospitals, we have a quality gap, and this network focuses on that, where more than 1 million newborn deaths could be prevented by closing that quality gap. And that's highlighted by the Lancet Healthcare Commission, of Quality Healthcare Commission. So moving more quickly on to Thrive, ensuring health and well-being for every newborn, everywhere. This is a fundamental way for nations to improve their economic development. If we don't do better for small and sick newborns, our national economic development will be like swimming against the tide. Important both for survival, but also for growth and development, particularly in the first 1,000 days, which determines a lot of your life course. Neonatal conditions alone, and particularly preterm, this is driven almost entirely by preterm birth, account for a very large proportion of the global burden of disease, indeed 3 times that of AIDS and similar to that of cancers. So what do the numbers say about that? Well, importantly, more focus on fetal health and growth, vulnerable newborns in utero, preconception care, and looking at more innovation to prevent low birth weight and prevent preterm birth. And the data message for that is we must measure birth weight better and also gestational age. So finally, transform. We have said we need to change survival, we need to change thriving, and to do that we need to reach these babies and their families, especially women, and change social norms. All of us looked like this baby once, vulnerable, hopefully we cried, but we don't enter the world equal. And what this report talks about applies to every part of the world, high-income countries, which are really shifting a big focus on disability-free survival. That's how we need to think everywhere. Upper middle-income countries with a risk of over-medicalization. An invisible world still of 44 million births happening at home. And then low and middle income countries where we've seen this shift into hospitals, but we need to address quality of care. So if we turn that picture, the world on one slide, 4 worlds, into a public health approach, this report talks about the 30 million newborns that are particularly vulnerable. But all 140 million newborns need effective care at birth, and their mothers have a critical right for their own care and for respectful care. There are 20 million that will need at least some special care, and 8 to 10 million newborns with severe complications, where if we don't have a sense of urgency and act quickly, that's where most of our deaths come from. And this links to a loss of human capital, surviving, thriving, but also thinking about what happens to families and parents. Having a small or sick newborn is a very stressful experience. And one of the beautiful things about this report is the shift to family-centered care and bringing in parents' voices. So I hope you will read the report. You will find parent stories, which are powerful from all over the world. This is a pediatric nurse whose child was born preterm and her story. So as I finish, it's important for us to know that we move forward together as a community to transform health and information systems. We need the data to drive change, but we also need to challenge social norms. Collecting the data is not enough. We need to use that data to show that it's no longer acceptable that newborns are just born to die. Yes, we need to count them. We need birth certificates and death certificates as part of challenging those norms. We need to hold funerals. We need to give bereavement support to families. This report shows us that the time is short, there is urgency, that we can have a big return on investment, that this is achievable, especially if we focus on the quality gap for small and sick newborns in hospitals, and that we do have data. We need more data, but we have data to drive action. There's a lot more information in the report and in other sources. And many who were involved in the report, as Ornella said, more than 94 authors. I'd particularly like to thank Stephanie Kong, who's been critical in helping all of us with these slides. And I now pass the baton to my colleague, Ashish Casey, who will talk to us about the importance of considering equity throughout our focus on small and sick newborns. Thank you.
Thank you, Professor Zoe. Yeah.
Go ahead, Ashish.
Yes. So thank you for this, Professor Zoe. So I'll be presenting you all on the Nepal's progress on newborn survival and taking the equity lens as a measure. So this presentation is part of the Nepal series that we had done for the Journal of Maternal and Newborn Health on the trends on newborn death in Nepal in the last 15 years and the SDG progress and the targets and the quality of care for mothers and newborns in health forces of Nepal, and out-of-pocket expense that families have to take care of for the management of sick newborns. So if you take the last four DHS that's done in Nepal in, between 2001 to 2016, then the annual rate of reduction for newborn mortality has been almost 4% annually between 2001 to 2016. If you take the 5 years average, then between 2011 to 2016, it has been 8.6% annually, and which is a good progress in relation to other countries in South Asia. But there have been, but if you disaggregate this progress by the wealth quintile, then what we see is that the highest progress has been made in the babies born to the richest families and the slowest in the poorest families. So in the highest progress is among the richest in 6.3% between 2001 to 2016, and the poorest family is 2% between the same period. And you might see this is the same trend between different time points between 2001 to 2016. if you use this projection or the annual rate of reduction of between the different wealth quintile and project their trajectory on meeting the SDG target of having 12 deaths per 1,000 live birth as per the target, then what we see is that Nepal is on track of achieving the SDG target. So it is on track to achieve the SDG target by 2030. But if a baby is born to a richest family, then they have already achieved the SDG target of newborn mortality. But if a baby is born to a richest or poorest family, then these babies will only achieve their target in 2068. So that's almost 38 years after the end point of the SDG time point. So there's inequity. There's an equity gap between the poorest and the richest in terms of the mortality and survival. And this is more been seen in terms of the quality of care as well. So in terms of the quality of care, this is based on the secondary analysis that we had done from the Nepal Health Facility Survey, which basically shows that the quality of care for mothers and newborns in health facilities is suboptimal in terms of basic newborn care services. For example, the application of chlorhexidine ointment for umbilical stump is only 71% in government hospitals, while it is poorest among the private hospitals, which is 32.3%. And if you see the application of tetracycline ointment for preventing eye infection, then it's poorest in the private hospitals, which is 6.3%, and it's not very good even in the government hospitals, which is almost 14.5%. The provision of BCG vaccination for newborns is poor and is poorest in the lower health care facilities like primary healthcare centers, which is 11.5% in the primary healthcare centers and 10% in health posts. In terms of the out-of-pocket expense for sick newborns, and this we had done from the 12 hospital studies in the far and the Midwestern region of the Nepal, which basically shows that of the out-of-pocket expenditure proportion, 48% of the out-of-pocket expenditure is been accounted by the accommodation that the caregiver needs to incur while staying in the hospital to take care of newborns, while 30% of that out-of-pocket expenditure is to travel to home or travel from home to the health facilities. And the remaining 20% is the treatment cost for investigation, treatment, and for management of supportive care management. In terms of the cost of care or cost of out-of-pocket expenditure that family needs to take care of by type of newborn morbidity, then the highest out-of-pocket expenditure takes place if the newborn is admitted for preterm birth complication, which is almost $52.8 for preterm birth complication management, and lowest for other causes, which is almost $21.3 for managing sick newborns. In terms of the out-of-pocket expenditure by duration of stay, what we see is that if the babies are staying longer, then the out-of-pocket expenditure also increases, which is proportional to the duration of stay for the caregivers. And if the duration stay is 1.3 day, 1 to 3 days, then it's almost $22 per day. So what does this number indicate for futures of mothers and newborns in Nepal? So Nepal is on track to reach the every newborn target, the SDG target of 12 deaths per 1,000 live birth by 2030. However, the distribution of death among the poorest and richest is widening, and if this continues, then the poorest will never be able to achieve the SDG target by the SDG time point. The out-of-pocket expenditure for sick newborn exists and varies by duration of stay and newborn morbidity. The quality of care is poor, suboptimal in all level health facilities, and poorest in the private healthcare facilities and lower level health facilities. For the policy implications, there's a more need of having universal health coverage, more access to high quality health systems for mothers and newborns, reducing financial barriers for sick newborn care, especially in times of this COVID pandemic, where there is a less attention to mothers and newborns and more attention for treatment for infected cases or preventing infections. So I now hand over to Udva.
Uduak, you need to unmute yourself. Unmuting you.
Okay, thank you. Can you hear me now?
Yes, go ahead.
Okay, so thank you, Ashish, for handing over to me. I'll be talking about hospital-acquired infections in a West African neonatal unit. And as Joy has mentioned, that there are over 600,000 neonatal infection-related deaths every year. And most of these occur in sub-Saharan Africa and Southeast Asia. So what do the numbers say about infections in sub-Saharan Africa? So in a very large systematic review, looking at studies that had published data on neonatal infection etiology from sub-Saharan Africa between 2008 and 2018, looking over 52,000 neonates, there were large data gaps as many countries didn't have any published data on etiology. And also there was challenges with inconsistency in reporting. And so there were different case definitions used, different laboratory methods, and not all the data was available in the publications. And the data show that for neonatal bacteremia sepsis and neonatal meningitis, apart from Staphylococcus aureus, which was common to both conditions, the pathogens were different. And so the pathogens causing neonatal meningitis, group B streptococcus and streptococcus pneumonia, are possibly preventable by vaccines, which are either in existence or in development. But for the pathogens that cause neonatal bacteremia or sepsis, E. coli, Klebsiella, there are no vaccines. And also what's interesting is that these are pathogens that are also attributed to hospital outbreaks in neonatal units. Also, the review found out that there's increased resistance to WHO recommended antibiotics, especially the first and second line antibiotics across the region. And one of the key messages from this paper is that there needs to be standardized reporting. And if the authors now use the stroke neonatal infections guidelines, which is an extension of the stroke guidelines, this will streamline reporting and will result in less data wastage, as we'll be able to compare the data across countries and across regions in sub-Saharan Africa. And so looking at the case of Gambia, which is a very small country in West Africa, what was found in a very large audit of neonatal admissions in the largest teaching hospital showed that over 94% of newborns admitted into the unit received antibiotics, and some babies received 2 antibiotics during their stay, and some babies received up to 3 or 4 antibiotics at different times. But what was more striking was that there was a mismatch between the use of antibiotics and investigation. So only 2% of these babies had an investigation result available in their clinical notes. So over 91% of the babies were not investigated, but they received antibiotics. So obviously there is a clear gap for more cultures and less use of antibiotics, as injudicious use of antibiotics is contributing to antimicrobial resistance across the region and globally. And so newborns, babies admitted in hospital or who are born in hospital are exposed to infections from multiple sources. And so in the same neonatal unit between March and December 2016, there were 2 outbreaks. So the first of all, between March and August 2016, there was a cluster of cases due to Burkholderia cepacia, and 49 cases were reported in the unit. And after a series of interventions to contain the outbreak, in September, we didn't have any infections at all. But then between October and December, there were 2 simultaneous outbreaks, which were distinguished by whole genome sequencing to be 2 strains of Klebsiella. So Klebsiella pneumonia, Klebsiella quasi-pneumonia subspecies simile pneumonia. And what was important here, that there was a gap in identification of the outbreak. As you can see, it was only towards the end of March that it was suspected that there was an outbreak. And there was a high case fatality rate among babies that were infected with these pathogens. And whole genome sequencing, which was also used to investigate the outbreak showed that the Burkholderia pasture was recurrent and endemic in the ward, and the Klebsiella pneumoniae was a more recent outbreak due to more recent introduction of the pathogen into the ward. And I must note that all the Klebsiella isolates were multi-drug resistant and ESBL producing, but they were sensitive to the carbapenems. An investigation of the outbreak showed that there was intrinsic contamination of IV fluids and antibiotics during preparation and administration in the ward. And the investigation outbreak also revealed that infection prevention and control in the unit was suboptimal. So lastly, what can we do to improve quality of care for newborns in countries with high burdens of neonatal deaths due to infections? Well, obviously, we need to prevent these infections. We need to care for the newborns and improve the quality of care. We need to make sure that we're detecting these infections early. And so more cultures need to be done and other diagnostics with possibly point of care diagnostics should be developed. And then the laboratories need to work hand in hand more closely with the wards to improve laboratory support, make sure there's rapid response and results are returned on time to enable clinical care. And also we need improved systems. So policies and guidelines for infection prevention and control, regular audits, which will feed back into improvements in quality of care. And we would also need to make sure that neonatal units have an infection prevention control plan and an infection control team. And so I'll now hand over to Dr. Onelo Lincento from WHO. Thank you.
Yes, good. I'm just sharing the slides and I'm with you. Okay, good. So I will briefly present what are the latest data on COVID in pregnant women and newborns. What you see in these slides is just a web page of WHO, which is focusing specifically on issues of maternal, newborn, child, and adolescent health. So fundamentally, we have a very few data, quite limited data on the clinical presentation as well as on the perinatal outcomes after COVID-19 in pregnancy and in puerperium. But based on what we have so far, these are the few the highlights. First of all, there is no known difference between the clinical manifestation of COVID-19 in pregnant and non-pregnant women of reproductive age. So no difference so far. Second, women who are pregnant and COVID-19 positive don't seem to have higher risk of severe disease compared with the non-pregnant women or the general population. Of course, if so, similarly to the general population, if they have preconditions like diabetes, cardiovascular disease, hypertension, etc., they are at higher risk of complication of COVID as the general population. Third, there is a lot of uncertainty at the moment on the possible increased risk of negative maternal and neonatal outcomes. Fundamentally, we have more, because the epidemic is relative new, we have more data on the regarding the third trimester, and there are some reports on pre-labor rupture of membranes, on fetal distress and preterm birth, but not such big numbers that make us to think that the risk is real. So at the moment, there are many countries have started cohort studies of pregnant women to roll out, to understand better how COVID-19 can affect pregnancy and pregnancy outcomes. And for what concerns the newborns, so we have even maybe a bit less data. So far, there's been very few cases, if you consider the millions of people who have been infected with COVID and the high number of women who have already been pregnant or during this months of the pandemic, in reality, so far, only few cases have been reported of newborns confirmed COVID positive, and all of them had either mild disease, mild symptoms, or no symptoms at all that were attributable to COVID-19. Also, very good to date, the live virus has not been found in samples of either amniotic fluid or cord blood, vaginal discharge, or even in neonatal throat swabs. And however, there's been a small number of babies with positive serology or PCR at birth, but it's not clear how they were contaminated. I mean, so far it doesn't seem that this support evidence for vertical transmission. The amniotic fluid, as I said, and cord blood so far has been tested negative and also the throat swabs of neonates delivered by cesarean section. So this again supports no vertical transmission. And for the breast milk, we heard about a report, but it's still unpublished, of 2 mothers in which COVID positives whose breast milk samples were positive for viral particle, for RNA. And now we are waiting for the reports on viral culture. And that's the data basically is really are very encouraging from the point of view of continuing with the recommendation of allowing all skin-to-skin care, even if they are COVID positive, immediately after birth, and allow them with the proper IPC measures to breastfeed and to provide this kangaroo mother care in case the baby is not prepared. We also don't have, there are no published reports to date of babies born with any signs of COVID, if they are born from asymptomatic mothers who have developed later on COVID-19. So this is basically the information on the data. I would like now to hand over to Benedict Water from the Network for Improving Quality of Care for Maternal and Neonatal Child Health to facilitate the discussion of the webinar. Thank you.
Thank you, Ornella. We have about 15 minutes for questions, 15, 17 minutes. So please keep typing them. We got a few. The first one was for Joy and doing a presentation, asking what indicator can be used to track development.
Yeah, thanks so much. And really critical that we measure coverage and quality of care. And for kangaroo mother care, there's a new study which has been led in Nepal with Dr. Ashish in Tanzania and in Bangladesh to validate indicators for kangaroo care. And that will be published shortly, and it suggests that admission to the KMC unit plus a few other targeted items would be both valid and feasible way forward. So I would encourage you 4 weeks from today to join the presentation on the chapter on data from this report, when there will be some highlights from parts of that study, the EN birth study. And we won't be able to measure everything in routine data, so we also need local quality of care initiatives and action on data and use of that data, which is critical. Thank you.
Thank you. And as a follow-up to this, Edwin Mangala made a comment that it's one of the challenges to improve quality of care for women and newborn is having easy to measure quality of care indicators that can be measured as part of routine data, without increasing the workload of the healthcare worker. And he also said that the quality of care indicators are hardly part of the National Health Information System. He's talking about the experience from Kenya, and he believes most of Sub-Saharan Africa. Do you have any example of countries that have successfully institutionalized quality of care measures in their routine data collection of HIMS?
Yeah, I think it also depends what we're meaning by quality of care. So sometimes it sounds like a religion, quality of care. We need to be very concrete about what components of provision of care and which components of experience of care. So for provision of care, we need to be selective, exactly as the colleague says from Kenya. We can't put everything into a routine register or the routine HMIS or DHIS2 system. So we need a mix of a selected number of valid and feasible and used, and then more targeted local quality of care ones. But I think maybe could I also ask Ashish to comment on this, because he's just been part of running a big quality of care network and trial in Nepal.
Yes.
Ashish, we don't hear you.
Yeah, can you hear me now?
Yes.
Yes, so we have been running a multi-centric trial on step-based design on quality of care, quality improvement process. But I think one of our major learning has been the accountability systems within each health facility hospitals for improving measurements and using that measurement for improving the quality of care. So as Professor Joy mentioned, I think measurement is key to ensuring the quality of care, tracking progress, but also using that measurement for improving accountability in each health facilities. And we have other tools such as PTSD tool as and other measures to improve the quality of care. But I think the most important one is accountability by leadership towards measurement.
Thank you. Another question directed at Joy. How can we go about developing investment plans for SSC governments for stemming NML, given the short timeline until the end of the SDG?
That's a brilliant question. I can't see who asked it, but this is critical.
Steve Adudans.
Steve Adudans, my friend, Asante. Yeah, I mean, the data that we have needs to be used not just to improve quality of care at the interface, but also to make the case to policymakers, and quite often it's finance or planners, not people who are already the converted. So, you know, maybe on this webinar, most of us are already committed to this. I know many of you, I see many friends' names here who are already working all over the world on this issue. But how do we put together the data and the tools to make the case? I loved what Ashish showed about collecting the out-of-pocket data. So, you know, countries are investing in universal health care. Sometimes newborns or mothers or other critical parts are left out of the financial protection side. But then on the provision side, quite often, you know, maybe we even build maternity hospitals where we forget to build a ward for newborns. We don't have floor plans. So I'm part of a network called Nest 360. And we're going to have an online open access learning platform later this year. And we're collecting, for example, floor plans, tools, ways to move this forward. We'll have a group of economists. I think Megan Bruce Kumar is on this line as well. So we need to also mix the disciplines we use. We need planners, people who think about infrastructure, engineers. We learn a lot from engineers. So I think making the investment case, we have to think differently. We have to listen to the data that people need, and then we need to package that data in a more usable way and think about important infection prevention. A lot of the things Uduak has said, you know, we really need to restructure units differently to have water and sanitation and space.
Thank you. I now have a question for Ashish from Budi Setiawan, asking if the coverage increase annually of community-based newborn care for poorer and rural community in Nepal, and what are the bottlenecks around that? Sorry, she asked what is the coverage increase annually and what are the bottlenecks?
Yeah, so we just did a corporate estimation on based on the DHS data from last 4 years of data on the coverage coverage increase. So there have been there have been a coverage increase for utilization of health services, especially the health insurance delivery, from almost 8% in 2000 to almost right now to 64%. And there's a huge coverage leap, but the problem is the quality of care within the health facilities. So the community-based programs has been very vital to bring women to the health facilities, reducing the first and the second delay, but the third delay is still a challenge, and that challenge encompasses the whole issue of reducing the intrapartum related deaths, especially the intrapartum stillbirth and first day mortality. So yeah, the coverage has increased, but the most critical thing is the effective coverage of interventions within the health facilities.
And another question for you, Ashish. The assumption has been that private hospital have a offer higher quality care than public health hospital, but that doesn't seem to be the case in Nepal. Can you give any possible reason for this? And this is a question from Edwin Mangala.
Yeah, I think the problem is basically the lens that we see in. So we usually see private hospital as buildings, infrastructures, nicely built facilities and infrastructure. But the problem is the implementing the standards within these health facilities. One of the problem is usually the public health system more focuses on the government health facilities, training them and providing quality interventions. But usually these private hospitals are left out on getting those trainings and standards. And so that is one of the major challenges for not encompassing private hospitals providing the optimal care or optimal care for newborns, or at least basic newborn care services.
Thank you. Now a few questions for Uduak. Regarding the Burkholderia cepacia, I apologize if I'm saying this wrong, outbreak in the Gambia, was isolation of this organism of clinical significance, and how was this assessment done? And were the neonates treated with targeted antimicrobials? And this is a question from Harish Kumar.
Okay, thank you, Harish, for your question. So yes, the pathogen was identified by blood culture, and the newborns were treated. Fortunately for those babies, the Burkholderia was not resistant to the antibiotics we were using. So the babies, a number of them did recover, but we still did have high mortality rates. And the second question was?
And were the neonates treated with targeted antimicrobials?
Yes, they were. So they were treated with the WHO recommended first and second line antibiotics, and they recovered. But the patients with the Klebsiella, we had higher mortalities among those because the pathogen was multi-drug resistant.
Another question that's most, I think, directed to you as well, Uduak, from Asumta Kayin Moramwali. What can be done at the global level to influence country to avail cultures in lab to avoid misuse of antibiotics, and also influence donor to support the rehabilitation building of neonatal services?
That's an interesting question. I think one of the things is that blood culture systems need to be cheaper. So automated culture systems are quite expensive, and many countries in sub-Saharan Africa and developing countries, they struggle with the cost of the culture. So the equipment itself, the bottles are quite expensive. And so you hear clinicians thinking about other things, supportive tests like CRP, but CRP doesn't provide etiology data, and it doesn't provide antimicrobial sensitivity data. So we need a lot of advocacy for cheaper systems. And then we also need to get our governments committed to making sure that we have the sufficient infrastructure.
Thank you. Thank you.
And can I just add briefly on that infection? I think also everybody on this line has a role to play in this, because doing blood cultures, it's about a culture of doing cultures. So if you remember Uduak's second slide, 94% getting antimicrobials, but less than 3% getting a blood culture result. You know, yes, we need to find ways to make it more accessible, but it's also for all of us to demand that, as also Ashish was saying about, you know, accountability of within our hospitals. If we're looking after babies in these units and they're sick, you know, in Uduak's data, you're seeing you've got 49 cases, and there was a more than 50% case fatality rate. And sometimes we don't even pick up these outbreaks. So all of us need to look at detecting, preventing, and really changing this, because otherwise we're actually having babies die in hospitals that are preventable, and we're not measuring it.
Yeah, another follow-up question on the use of antibiotic, a very specific one from Lamek Luwanda, asking, is there the use of POCT like CRP in determining when to use antibiotics?
So I guess that question is for me.
Yes.
So yes, so CRP, as I mentioned earlier, it might provide information on possibly when to start or stop, but it doesn't give etiology data. And so at the end of the day, it's not really very helpful, even though a lot of people might think otherwise. So if you go back to the slide I showed on publications on neonatal infection etiology across sub-Saharan Africa, you can see that 16 countries didn't have any data, and 19 countries had only one publication over 11 years. And if we continue to focus on using tests that don't provide the etiology data, then possibly 5-10 years down the line, this map is not going to change. And so while I would not advocate that we invest in investigations that will not provide the data that we need.
Thank you. Finally, a few questions for Ornella on the presentation on COVID-19's data. For a question from Harish Kumar, how do you provide KMC from a COVID positive mother to a COVID negative newborn?
You provide KMC. Thank you for the question, first of all. We can provide the KMC basically in the same way as for other mothers, except that the mom has to wear a mask during the time she is still COVID positive, which will be for 2 weeks, 2 weeks after the end of the symptoms, or yeah, after she's tested twice negative. Then there is, of course, she has to wash the hands every time before breastfeeding and after changing the nappies, but this is not very different from actually what is recommended in general. And so basically is this one, and of course she can do, but she needs to be also at a distance. The room has to be done organized in such a way that she has to stay either isolated or at least 1 meter far from other beds, other babies, other mothers. So basically that is not terribly different, and is more to make available the mask in their facility and eventually home to wear the mask during the kangaroo mother care.
Thank you. I'm going to take 2 more questions, and the next one is still for Ornella. From Edwin Mangala on one of the questions that they keep saying from midwife in Kenya is on whether or not to separate a mother from a newborn at birth in the COVID-19 context, especially if the mother is COVID-19 positive.
Again, we have reviewed all the evidence during, and we are still watching very carefully all the reports. We are in contact with many hospitals, but I'm saying also hospitals that they are collecting data very, very seriously in the European countries, and we confident that on our recommendation that the mothers should not be separated, even if they are COVID positive, from their babies at birth, so they can be allowed to provide the skin-to-skin care immediately after birth. Of course, the healthcare providers have to wear, in this case, it's the healthcare providers who needs to wear the mask, the medical mask, to avoid the contamination during the process of delivery or whatever, and so when they provide care to the mother. But for the point of view of the mother, she can be, and the baby, the risk of separation and not providing her breastfeeding are much, much higher than the risk of COVID in newborns. First of all, very few babies get COVID. Second, if they have mild diseases. So it's not, there is no reason for separating them from the mothers.
Thank you very much, Anela. And last question for Joy by Dr. Rajiv Tandon, asking if there is cost-effectiveness data comparing NICU with SNCU and HBNC.
Hello, Rajiv. Lovely to see you online. Obviously, India has the fantastic system with probably the most rapid scale-up of large-scale special care for small and sick newborns. I think, a rigorous design to compare the NICU level with the next level, would be difficult to institute. And I think a good system needs both. The answer would be, how do we do better to use data, referral systems, and so on to make sure that the babies who need the NICU care get it, and those who need SNCU care get it. And learning from that. And then a fantastic thing about India is the data set and this afternoon's session. So repeating, but with different angles, this webinar later today will have Gagan Gupta, who is one of the key people from India who's been involved in the data set for that special care network in India, which is just an incredible and useful data set.
Thank you very much, John. Now we're going to close the question and answer. We're running out of some questions we did not have the time to address. I'm handing over to Anela Lincetto to close the webinar. Anela, you're on mute. You're unmuted now.
Oh, thank you very much. So I thank you to all for your participation to this webinar and for your questions. I hope you enjoyed the webinar as I did. We heard a lot, on the key data and how important it is to use the data properly. We heard about the data on survive, thrive, and transforming. And the message that we have every year 30 million newborns that are the most vulnerable, that are requiring inpatient care, and how we need to invest in the care for them. But the progress is challenged by, for example, COVID at the moment, but also poverty or social determinants of health or quality of care issues, as we heard from the examples of the countries. But we also know that most newborn deaths and disability are preventable. And so, and we need all to continue to work and to demand better care, better services for the newborns. And now in the next, I would like to invite you also for the next seminar, when we will, which will be on the 3rd of June, where we will discuss what are the health system requirements and what we can do to transform neonatal services and make an accelerated progress possible. So thank you very much again, and have a very good day.
Thank you. Thank you for your time. Bye-bye.